This is my team, Dr. Emilio Garzo, Lucci, and Nicolas. I'd like to start with the electrical concept because the CRT objective is a mechanical improvement, but it uses principle of pacemaker and electrophysiology to modify the electrocardiogram hemodynamic behavior. But the therapy is initially driven by changing the electrical property. And the question is, what should we most pursue? To resynchronize or not to desynchronize the patients? I wrote an editorial review if the traditional resynchronization therapy is obsolete, and if the Parahisian pacing is the new paradigm, really simultaneously appear another editorial or review in circulation with the same question. We have been working in a Parahisian and fixed pacing from 1993, but we paced in the Parahisian area and the Hisian area, but at those times there were not screw-in catheters. But we continue working in this area. The point is to pace near of the conduction system, because the speed of conduction, the velocity of conduction, you are near of the Purkinje neck is really faster. We try to find this zone through Synchromax. About the different names, the different authors that call the sometimes selective hispanic pacing, non-selective hispanic pacing, we prefer the name of Parahisian pacing, that is same to non-selective hispanic pacing, because we pace through tricuspid valve and pace in the right ventricle. This catheter is indicating the position of his bundle. But if you pace in this area, in the right ventricle, the tertiary are good and good are wave. This is a difference with the selective his bundle pacing. If you pace in the right ventricle, you don't have problem. This is an X-ray with a pacemaker. We don't use special tools or special sheets, but we are not against of special tools. But we implant also defibrillators in this area with the same results. I have a paper published some years ago with a non-selective hispanic pacing with a special wave. It's a overimposed wave called biphasic waveform to resynchronize patient. This is a very complete paper that was published for problem of confidentiality in 2017, but we started 10 years ago with this research. We paced with this special wave in a Hisian area. We measure blood pressure, intraventricular blood pressure of the left ventricle with a miliar catheter. We measure echo tissue, and we're recording the activation of the left ventricle lateral wall with a catheter in the coronary sinus. But the result of this this paper, this work, was improved hemodynamic parameters. All these patients have a left bundle branch block and heart failure, and some of them was pre-transplantation. But when we finished this work, we tried to find some non-invasive parameters to know which is the base or which is the parameters to know if the patient have electrical synchrony. And this is why analyzing all the ECG of this paper, we start to with the project of Synchromax. We have the two papers. This is a bioengineering paper explaining the mathematical model. This is another paper, more clinical, with a clinical aspect. But the method is very simple. Is to compare two leads, the T2 and V6. T2 is a good lead to know the activation of the septum of the right ventricle. And of course, the V6, you can measure the lateral wall of the left ventricle. We compare amplified and processing this signal, and we can know the overimposed, if the curves are overimposed or no, and we create an index to measure the electrical desynchrony. Really, the curves are very simple. Nowadays, this is a prototype, but nowadays we have the device finished and available. We won the prize in the World Congress of Electrophysiology with the result of the Synchromax. The screen is very simple. You have here the ECG, all right? And here you have the two curves overimposed. The curves have an index of the synchrony, and it's very simple because it's the same to the light traffic. The green is okay, yellow is intermediate, and red totally desynchrony. Also the beta minus, this is a curve, and you have the measurement of the duration of the QRS automatically. After studying more than 6 doses of patient, we perform this chart of different curves. Really, there are a lot of curves, but this is only a template or a model to explain some of them. In this line, you have patient with low basin. This is a normal patient with overimposed curves, with a low index, green. Patient with a right bundle branch block or left axis deviation with a intermediate desynchrony. And of course, in general, the left bundle branch block have a totally are desynchronous. This is a very important point. When you have a CRT, in some cases are totally desynchronous, as shown in these 7 curves. But if you play with the VV interval, you can adjust the both curves and overimpose. But the curves are negative because the polarization in the CRT is from the apex to the base. And really, this is not optimal, it's ectopic activation. On the other hand, you have the Parahisian patient here, and this is an overimposed course, but the QRS is wider. But then you can know that this is not important. But another interesting phenomenon is that we perform a prospective study with patients with pacemaker. And we found that some of them, based in the apex, are totally desynchronous, and another 50% are synchronous. Of course, negative, but synchronous. But if you compare these curves, electrical curves, with the optimized CRT, are similar. In other words, you can find similar curves that obtain of the CRT, pacing in the apex, looking with Synchromax online. When you paste, you can know the synchrony on the curves online. We work with a lot of groups in different countries of South America. This is a paper of a friend of Osvaldo Gutierrez from Costa Rica. He showed that moving a catheter only a few millimeters, you can obtain different curves. For example, this one is a very nice curve with a low index overimposed, and it's a little wide. Another are similar, but it's not perfect. Of course, another place, but very near, the index of the synchrony is a little higher. But you can pace and you can test which is the best place. Our experience with the Synchromax was presented in Munich in 2018 with more than 300 patients, including pacemaker and defibrillators. We can find good searchers and good R-wave in all the cases. Really, with the index of displacement was very, very low. Really, we implant all the pacemaker and ICD in this area until nowadays. About the non-selective hispanic pacing, we published recently this technique to find the place to pace, and really using a conventional screwing catheters. We don't use special catheters because we're planning that this technique is for everybody, not only to electrophysiologists, because the curves are very simple to interpretation. The surgery is very, very fast. We don't use a special sheet. This non-use special sheet is very important in a country that spend money in health is so critical as in our country. Of course, it's a reduction in implant times and have a low long-term complication. We test sheets and special catheters, and really we spend a lot of time. We need another, for example, another recording, but it's not necessary when you use this this approach. About the result of the hispanic pacing compared with biventricular pacing, there are a lot of papers that, in conclusion, the hispanic pacing may present a physiological alternative to CRT, and this was published some years ago for the group of Longarsen. But recently, this method is of resynchronization is for this group. They implant the Parahisian pacing in patients with heart failure and left bundle branch block. And the result that this therapy of his resynchronization produce a better clinical outcome than biventricular pacing. I say that we work with a lot of groups. This is a group of Claudio de Zuloaga. He's an Argentine electrophysiologist that works in France also. The paper is, what have we learned about ventricular synchrony by using Synchromax? Really, he studied more than around 275 patients and have very interesting results that he said that not only the left band branch block produces this synchrony, sometimes the association with the right band branch block and left axis deviation provoke this synchrony. When I read this paper, I was very happy because it was the same concept that we had previously. But when another groups arrived at the same conclusion, really is very interesting. But he have one finding that is very interesting. In patients with a normal QRS, there are a small percentage with marked anomaly in ventricular activation. This is maybe the precede most important conduction disturbance in the future. I don't say that you must face in this kind of patient, but really is a very interesting finding because around the 4% of the patient with heart failure present this slow desynchrony that is not apparent in the ECG, but you can find in the Synchromax curves. Now Synchromax is around the world, and of course in Latin America, and some in Canada, some teams in Europe. About the another group of the research, this is a paper of Hugo Villarroel and Raúl Garillo, that he published a book called Heart Failure, Desynchrony and Remodelation. And really it's very interesting because he said that the echo, by echo, there are not relation with the duration of the QRS. In other words, one old concept that the duration of the QRS is very important in the resynchronization therapy, he said that it doesn't have duration, including in the Parahisian pacing. If the curves are synchronous, but why is not important when you are talking with the echo and resynchronization. I wish that Hugo can answer if you have questions about echo, because I am electrophysiologist only. And of course, Raúl also can answer questions about this paper. Some examples are very easy to know, to see, sorry. This is a left band branch block completely desynchronous with a notch in the different notch in the Synchromax curves. There are a lot of patients that have it also. They have a left band branch block, but are not the same. This is a more synchronous. Despite that, of course, is the synchronous for Synchromax is not the same case. There are different types of left band branch block. And this is another interesting example of left band branch block. Both curves are overimposed. The QRS is wide, but the curves are overimposed. What happens if you implant a conventional CRT in this case? Probably the patient is worse, and probably you are in front of a non-responders. About the left bundle, left axis deviation, the left bundle branch block, in this case, when you base in the Parahisian area, you can observe that all curves, both curves are overimposed. This is not a perfect index, but of course, this is better than the previous one with a complete left band branch block. We improve the electrical synchrony and improve the mechanical synchrony also. But this is only we are talking about the electricity. In a patient with left axis desviation, you can normalize the axis and you can normalize the curves facing in the Parahisian area also. And about CRT, I like to show this kind of curves and this one when you play with the VV interval. In this case, it's totally desynchronous, and this case is after adjustment of the VV interval. As an example, when you pace the right ventricular only, or when you pace the left ventricular only, they are totally desynchronous. But when you play with the VV interval, in this case, you can obtain both curves overimposed when you pace the right ventricular 20 milliseconds before the left ventricle. But there are other cases that you can find any curves that is synchronous. All the curves are desynchronous. This is a really true non-responder, electrically non-responder, because maybe a lot of curves, a lot of causes. For example, for example, the catheter is not in good position, the right ventricle or the left ventricle, really, but electrically, you can find that this patient is a non-responder patient. This is another very interesting point. When you have a patient with a hypertrophic dynamic cardiomyopathy, some years ago, the pacing was a treatment for the dynamic cardiomyopathy, hypertrophic, because you like to provoke the paradoxical movement of the septum. But if you remember the chart, some patients, when you pace in the apex, you don't know what happened, are synchronous. And if are synchronous when you pace the apex, you don't have paradoxical movement of the septum. On the other words, you can't provoke that the gradient decrease. But if you pace and you provoke electrical desynchrony, you can decrease the gradient, intraventricular gradient. We test this method in many patients, not a lot of patients. We have around 10, with echo intra surgery, with a Synchromax. And when we are looking for totally desynchrony, you can decrease the gradient. This finding can explain that previously in other papers, the results are controversial because in some cases you are working blind. It's impossible to know the results. Another case that we are facing in the apex is in the transcatheter aortic valve implantation, because we are not sure facing in the Parahisian area when the patient received the new valve, intracardiac valve. We solve to pace in the apex, trying to find synchronous curves. And what happened with the right band branch block in this case? You can normalize the curves facing in the Parahisian area and disappear the last part of the QRS. What happened in the Brugada syndrome? Really, what is a Brugada syndrome? Really, to be simpler, is a typical right band branch block. There are a consensus that the arrhythmogenic area is in the right ventricular outflow tract. And what's happening, you pace in the Parahisian area, and you can correct the right band blind flow. Probably saying the Brugada send me, Pedro Brugada send me, in Spanish say, well, man, hombre, si you suspendes la patente de Brugada, you don't have, no tienes Brugada. In English is, oh man, if you avoid the Brugada pattern, there are not a Brugada syndrome. And really, it's not true, but it's not totally true. But if you can normalize the QRS, it can provoke that the patient don't have shocks. On the other hand, some groups are using the radio frequency ablation, but everybody uses ICD or backup. And in this case, we prefer the Parahisian. And we have been working in this area many years, and we receive a patient with an electrical storm. We pace, in this case, in the Parahisian area, normalize the QRS, and the patient is free of symptoms for 5 years. Previously, she had a lot of shocks per day during 1 day each 6 months, more or less, and now is free of symptoms for 5 years. And really was a very, very successful case because another problem in the Brugada syndrome is that the pattern is intermittent and you don't need to pace constantly. With this line of thinking, we create a patent of one ICD to pace only when the QRS is wider. This is an example of the Brugada pattern, all right, with a delay at the end of QRS and the V1. And when you pace in the Parahisian area, you normalize the QRS. You can see here the transition and disappear the delay at the end of the QRS. This is an X-ray with the ICD. And as a conclusion, our mission is to develop the right side patient to maintain or restore the cardiac syndrome. We try to simplify the optimal lead placement and follow-up adjustment with this method, because it's very, very simple to see. Really, you don't need a learning curve. I think that previously we were blind workers because nobody knows what happened when you are pacing. I have a dream that all the pacemakers should be implanted in the Parahisian area, with the exception of the 2 cases that I showed previously. All the ACDs should have Brugada syndrome algorithm on and off, and all the device implants, follow-up, and adjustment should be done through Synchromax. Really, maybe only a dream, but maybe in some cases, some groups are saying that probably. Thank you very much.